role of palliative care in patients that have like a court-appointed guardian and there is no family involved when you think that they're not doing well? So what is our role? What can we do to get to involved?
So that's a good question. If they have a court-appointed guardian, and things are changing in Michigan a lot, and that you guys can add in what you think, but there is a state law in Michigan that a court-appointed guardian cannot make a patient a no CPR. It's a state law. It's been there a long time. They're just now starting to interpret it that way, but always, many guardians, they'll put them on hospice but leave them a full code, which is a whole other conversation, but there's also a law, the Dignified Death Act, that you can be a full code and still be on hospice, and it's sometimes an emotional thing, but we usually work with them to try to change that by the time they pass. But what I do is a lot of times write a letter to the guardian. I get the attending to write a letter saying that care is futile, harm is greater than benefit. That's what I put in my letter, and that we're recommending hospice. Many of them are very agreeable to hospice. Some won't even talk to you. One lady I called and said, a message said, if you're calling to limit care in any way, please do not leave a message. That's what the guardianship office said, because they didn't even want the conversation. Some will not even listen to it no matter who's calling. But how palliative care can help is conversate with the guardian and talk about how harmful care is, and get a second letter. So.
Ask a question. If you have a receptive court-appointed guardian and the burden outweighs the benefit, will you write a do not resuscitate order for the patient?
I will. Okay. Doctors, we don't have to resuscitate, so if the guardian says, yeah, they'd want to be comfortable or even they want hospice, I will write the do not resuscitate order in my hospital. How that carries over to other settings, but in the hospital, I will write the do not resuscitate order without the guardian's consent because it's medically harmful.
Question, so if a patient's in limbo between palliative care, maybe in hospice, and they go into AFib or their blood pressure's high, do you give them medication to treat that? Because I feel like that comes up a lot. No one's ever really sure what to do. I know you say comfort care measures are kind of a gray area, but I mean, if they don't get the medication, they're going to get comfortable if their heart's racing. So it's always like, I don't know if you could clarify that more.
I think having the conversation with palliative care is very important, but it's an introduction, and you still have to have informed consent and to identify the choices of treatment. So in a patient that has cardiac history that you know you're going to be dealing with, you know, the whole spectrum of things from AFib to pacemakers to whatever, that conversation has to start. And what I have to say, I agree with everything that Dr. Karen said, and you know, we have the spectrum of care from palliative care to hospice or end-of-life care. But the problem that exists right now is that often a palliative care consult gets done in the hospital, and maybe it even gets continued on after discharge after the hospital. But then that palliative type of service stops because palliative care service can be paid for out of the hospital as long as there's a skilled need. Once there's no skilled need still existing, then that palliative care service, maybe it exists with a hospice service in the community, it ends up stopping. So then all those other things, those choices that got made, those have to be made readily available to everybody else who's treating that patient. Some hospital systems, and the one that comes to mind foremost in my mind is Cleveland Clinic. If a patient gets on the palliative care service there, then they assume management of the patient, and that attending in the community doesn't continue anymore. And that's one way they can continue to be able to offer those palliative care services to a patient.
Yeah, that is a problem. It's not available across the continuum. In those patients, it's a comfort to control their heart rate, so I might give them a dose of something. I leave patients on their DIG through till they can't swallow, so they don't get that. But do they really need the telemetry? Those are conversations to have. Don't just treat numbers if they're not uncomfortable. But that's the time to say, you know what, this is what we thought was going to happen happening. They're suffering, they're short of breath, their heart rate's up. You need a decision today. I give families 48 hours. I don't let them take 5 days to decide anything. If they don't want hospice, you pursue with aggressive treatment and discharging.
Other questions? You over here.
And does it entail like your day-to-day?
Well, I think in the osteopathic profession, the last exam has been given, right?
You can't grandfather in anymore to being palliative care certified, but you can do it's a one-year fellowship. And it's just like geriatrics. I don't know if we talked about that, but geriatrics is only 1 year, and it can broaden your practice opportunities incredible. As a palliative care doc, you can work for a hospice, you can run a consult service, you can do inpatient, outpatient, home care services, you can do nursing home care. Same thing with geriatrics. For 1 extra year, you get incredible practice opportunity. You can become a certified medical director of a nursing home, but you now, to either be certified in geriatrics or palliative care, you have to do the 1-year fellowship. But I went into geriatrics because I wanted to have kids, I wanted to have a life. Sometimes I go to the nursing home at 5 in the morning, then in the middle of the day go to my kids' school and help out there, and then I can go to the hospital after. But the flexibility is incredible. You can do a lot of administrative work as a palliative care doc, or I'm sure these guys too, is doing mostly geriatrics. I do a lot of administrative work. So there's a lot of teaching. All schools need specialists like geriatrics. So it's incredible, but it's only 1 extra year. That's it. It's a palliative care fellowship. To now be certified in palliative care, I mean, you can practice palliative care and take courses. There's a lot of courses, but to actually be certified, it's a 1-year fellowship. And there's several in the country.
There's another question over here. Yes.
Consults for palliative care, because I've tried to make some referrals on patients that I thought were appropriate, and I have not been successful with insurance companies and that sort of thing. Like, do you mostly get your referrals through the hospital, or how does that work?
And there should be no problems with insurance companies whatsoever, because again, it's just like a cardiologist. I mean, I'm a specialist, but I do outpatient office consults, but not even really that many. I'm in the office a half day a week, so because I'm by myself. So there's just not that many palliative care services available. You probably have to send them to a tertiary care center to get outpatient palliative care consult, but there shouldn't be issues with insurance. But most of my patients come from the hospital, because that's where I am mostly.
But your geriatric specialist can also be involved in that kind of referral for palliative care.
Sure, yeah, for those conversations, symptom management, absolutely.
There are also hospice and home care, palliative care, do all of them, and you can refer to home care if they meet the criteria, and then they can go out, and there's always a medical director, and a lot of them are hospice or palliative care certified, and they can do a consult, and it's billable to Medicare if that's their insurance.
Other questions? Yes.
You're interested in the fellowship, so how would you go? You mentioned like a work study, like a part-time fellowship.
That's something we're looking at this point, and we've not started that. Mainly right now we want to get our geriatric fellowships up and going for the traditional track, but it's something that we hope will be available within the next few years. It is in our grant, and we're going to do that as we get finished with the piece that we're doing now. Other questions? Any last comments from our presenters?